Thank you very much, and thank you all. So when I was approached to do this talk, I thought, well, I'll use this to experiment on you guys at some area that I've been thinking about and talk about it in that sense. So a human right to health. Again, you say this is something that's taught, that's art, and the question is, well, what exactly would that be, right? It's easy for us to understand it at a moral level, right? There's a sense that the morality, it makes sense that we should have a human right to health. But what does it mean? What does a right mean, right? When we think about a human right, what does that mean? So I'm going to try and put it in that broader context of rights and how they're implemented, what the limitations might be, give some examples from other countries where it is actually a litigated constitutional right as opposed to our notion of it being a moral claim, etc. So there's the outline. Those are the different topics I'll touch, because in order to have this conversation, it's useful for us to think about what exactly is the international status of this right. How does it work nationally in some contexts? What ways can human rights be enforced? How are they normally enforced? And then I'm going to use the example of access to essential medicines, which I did work on some time ago, to just show you an example of how it might play out in a particular context. So that's the idea. And then the rest, I've just got some background pictures for you to watch, so you don't have to watch me. What's interesting is, so there's this notion of human rights. And what's interesting, when we talk health, we talk about public health. Then you talk about health care. And often, and you guys understand this better than me, you make a distinction between public health being something that is done collectively through epidemiology, etc., as opposed to individual health care for an individual. And that has real significance for any notion of a right to health. Because are you delivering health to a community collectively, or is it something that an individual has a right to? And how is that balanced? How does that actually work? And so if you go from a human rights perspective, of course, there's that very individual notion. All human beings are born free and equal in dignity and rights. That's Article 1 of the Universal Declaration of Human Rights. And so one of the critiques often of human rights is it is so individually oriented, but of course it hasn't stayed that way. There's also a collective notion of human rights, and I'll talk a little bit about that as well. So there's this idea, are we talking about human right to health with respect to individuals and communities in terms of the right? And who has the duty? Is the duty on individuals? Is the duty on governments, on countries, on states? Right? Who has the duty to actually provide this right to health? Short form, who's going to pay for it? Right? I mean, there's a way in which we have to think about how delivery might take place. And historically, of course, this conception has changed, particularly at the global level. If you think of the World Health Organization, which is the primary international organization dealing with health, you think about the difference between the Alma-Ata Declaration, which focuses on primary care, preventive care, and you look at what the WHO is talking about now and the way they're working, you realize that the world has also changed. So at the time of Alma-Ata in 1978, there wasn't a global context where we're talking about the new international economic order. This was the developing countries demanding access to development, etc. And within Alma-Ata, they actually talk in the declaration, they talk about the new international economic order. This was a way to deal with international inequality. The way that health was posited was there's such inequality, prevention is the basis. That's the way we have to look at health. Developed countries weren't that happy with it. The global frame shifts from that period of the new economic order to neoliberalism, right? The pressure on individuals on that this is for governments shouldn't provide all of this. And all of a sudden you get a completely different shape. You watch the WHO actually change. And I'll talk about that too with respect to access to medicines. There's also another way in which you think about the human right to health, and that is in terms of the ways in which there may be violations of those rights. And that was one of the more traditional ways it was thought about, right? If you think about what happened in the Second World War with medical experimentation, ethics, that all develops after the war, and that's a simple case where you can look at these are clear violations of a human right, and what's the response to that? Whether it is developing new ethical codes for doctors, for researchers, or whether it is criminalizing the behavior of the doctors themselves at the time, the doctor's trial after the Second World War, etc. And I'm going to put that aside in terms of the kind of how you respond to the violations of human rights. Because when we talk about the right to health, we're mainly thinking about it in that more positive side. And let me frame that for you in a second. So what is public health? This is the definition that you pick up from the web. It says, and you guys know it a lot better than me, organized measures to prevent disease, promote health, and prolong life, population as a whole. Right? It is that very collective notion of health, not an individual notion. And then I found this great list of the great successes of public health, right? Through vaccination, food safety, water. And for years, I remember when we were working in these areas, people saying, well, delivering fresh water will have the biggest impact to, and I'm talking about in South Africa post-apartheid, if you want to improve health, make sure people have access to clean water. So that's a very interesting way to think about public health in those broad terms. You know, Jonathan, climate change, right? This is where health is going to be impacted, but in that very broad way. And does it work to say a right to health in that context? Right? What does it mean? What does it require? So when we think about human rights, they're often presented too in this individualist way, right? These are the notions of equality, freedom, peace, etc., that should be rights of all individuals. That initial slide I showed you of that dignity of the individual. So what are the sources and nature of rights? If we think about rights, we often think about legal rights, as opposed to a moral right. So if you think about enforcement, you have to think about it in terms of that legal sense, not just the moral sense. And what does it mean to say that we have a right to health? Under international law, we start with the Universal Declaration, right? So 70 years, we've had the Universal Declaration. But what kind of status? You can't walk into court anywhere in the world and say, hey, I got the Universal Declaration, I have these rights. But we can't imagine that. There are some who say they have become customary international law and that it should bind all states in the world. But you know, the United States doesn't look at this and think they need to follow these rights. And the Universal Declaration is a whole panoply of rights. Now there's a distinction, and it often gets described as generations of rights. And so they talk about these human rights in these terms. They say first generation of political and civil rights, second generation of socio-economic and cultural rights, and third generation of environmental rights. And maybe there's a fourth generation that's got to do with indigenous peoples, etc. What's interesting is, of course, the Universal Declaration didn't break rights up that way at all. The Universal Declaration has all the rights. And in fact, they're spoken about as indivisible and together. That you can't actually say, no, there's this right, you can have that, but that's later. Right? Which is the way. So how did that come about? It came about mainly because the Universal Declaration in 1948 is a world that for a moment is unified post the Second World War. But in fact, by 48 already, the beginnings of the Cold War were getting going. And what happens is the Cold War divides this Universal Declaration into these different covenants. Now, why the covenants? Well, in order to turn this into actual enforceable law, countries have to get into agreement with one another, right? So they can agree to a declaration, not so hard, because we don't have too many duties that flow from a declaration. But once we agree to a treaty, we take on international obligations with respect to one another as countries. So the conventions that flow from this, that are adopted in 1966, it could have been a single convention that could have taken all the human rights and said, okay, now it's a treaty between countries, and these are obligations that you owe as the nature of the treaty. But instead, because of the Cold War, this was divided in two. And so you have the International Convention on Political and Civil Rights, and you have the International Convention on Cultural, Social, and Economic Rights. right? Two completely different conventions. What's interesting is the way, particularly the West, saw this is to say, well, these are negative rights, the political and civil rights, and those are positive rights, social and economic rights. And we can understand how negative rights might be enforced, but we can't possibly understand how economic, social, and cultural rights can be enforced. Because the perspective is this. A negative right means that the state shan't do something to you, right? They can't lock you up. They've got to do certain things, right? That's the negative right. The positive right, the state must give you something. So, you look at these rights, the right to housing, all right, the right to shelter. Does that mean I can walk in and say, I want a 4-room house, and the court must say you must give it? That's the way it's caricatured. I want to argue to you for a second that, in fact, all rights have both positive and negative aspects. And I can show it to you first with respect to the right to a classic civil right, the right to a fair trial. You'll all agree that the government can't lock you up unless they give you a fair trial. Otherwise, they're not respecting your human rights. Everybody acknowledges that. Then I ask, well, what does it take to give you that fair trial? Because if it's a negative right, if the government just doesn't do it to you, it sounds costless. Right? It sounds like that doesn't take much. The government just mustn't do that to you. But in fact, if you look at what it takes to give a fair trial, you have to have a judicial system. You have to pay judges. You have to run courts. You've got to run, if you're serious about it, you have people, defenders, public defenders, to make sure that there's equality of arms when you go to court. That costs an enormous amount of money. That is the positive side to that negative right. Right? Somebody has to pay for that. Right? And I can do exactly the same with the right to housing. Right? Because if I say you have a right to shelter, the positive side says, oh, the government better have a program to provide public housing or whatever, or we have an enormous part of that in the U.S. Under the tax system, we give you a break when you on your mortgage, right, in terms of taxation. That is a positive side to housing. But even more clearly, what is the negative side to a right to housing? Well, particularly in developing countries, and sometimes here with respect to homeless people, there's a basic idea that the government can't just come along and wipe out your house and say, go away. Right? This has been actually used quite effectively in some developing countries like South Africa today, where activists and lawyers go to court and say, you can't just bulldoze that squatter area, that informal settlement. If it's inappropriate that it's built there, that these people have built their homes there, if that's inappropriate, fine. You can remove it. But before you do that, you have to provide some alternative for those people. You can't just say, go away. Now notice, that doesn't require the government to build a house. That just requires the government to get out of the way if somebody actually wants to build their own place or needs to build their own place in order to have shelter. So you can have a negative right to housing as much as you can have that negative right not to be locked up. In the same way, all these rights have both, as I say, a positive side. And I think that now enables us to get into a better conversation about what it might mean to actually enforce a right to health. Right? There isn't just, well, it means you're going to be spending on people. Maybe it means creating some of the conditions or more preventative conditions so that people are able to stay healthy. But as you can see, that the rights to the economic and social and cultural rights. Now, one of the ways in which the international community or states have kind of got out of this one is they say, well, civil and political rights are enforceable immediately. Government mustn't do that to you. But social and economic rights, they're aspirational. Because there is language in the convention which talks about the fact that these rights must be progressively realized. So the promise that you make when you sign this convention as a state is that you'll progressively realize these rights to the maximum of your available resources. And of course, that immediately means many governments can just say, sorry, we don't have the money. Right? That's been the limitation in terms of the enforcement of these rights. And there's your international right to health, taken from the convention, but then So this is how it's described in the convention, and you can recognize the language is also in the Constitution of the World Health Organization. The idea that it's the most particular language there. Everyone has the enjoyment of the highest attainable standard of physical and mental health. The highest attainable standard. Now, what might that mean? Right? Particularly if you try and enforce that. Does it mean that everybody must get access to the best possible health care available? Right? Or does it just mean that it's what can actually be provided, or what system actually has to be set up? Many countries now, over 100 countries, have included in their constitutions a promise or a commitment to a right to health. Those countries have a more direct problem of how they're actually going to enforce that now, because it's a constitutional right. It's not just a kind of promise by the legislature that they'd like to help out politically, right? So it's not in, many legislatures also have it in statute, but of course they can always change a statute. But a constitution is a little harder to change. Now, many constitutions you can change by 2/3 majority. They're not quite as hard as it is to change constitution like the US Constitution, but nevertheless, that is often an issue. Well, what about how these rights are framed internationally? There's the World Health Organization framing the right to health, access to universal health coverage. I wonder too, well, what does that mean? Is that to public health, or is that to individual health care? And it's interesting because when you look around, you find that it gets framed in both ways, right? This right to health. There's a classic where, what is public health, they say, and then you look around and it's some individual, some collective, healthy workplaces, some preventative. There seems to be quite a mix. And as I say, you know it better than I do. They talk about a model, right, that addresses health or social problems in a comprehensive way. Very much that kind of collective notion. I'll stay there for the moment. Because what I want to turn to briefly is to say, well, okay, how are human rights normally enforced? Think about even the right against torture, not to be tortured. How are these actually enforced internationally? Well, through the UN system, there is basically a reporting system. Right? So if part of the International Covenant on Political and Civil Rights, then there's actually a system by which you can report. There's even a provision for individuals to take, if your country agrees, you can sign on, and there's a commission that you can go to and report that you've been violated, and they will take up the case. But the basic mechanism is something called naming and shaming. Right? You identify, you throw a light onto the violation so that people will be embarrassed and won't do it. That you reveal what governments are doing. And it has been effective. Right? Nobody publicly takes people out into the street anymore and says, look, we torture them. Right? They do it in the back room. They hide it away. That shows you something's changed. Right? They're not so open and clear about it. And a lot of those kinds of behaviors take on that form. But naming and shaming is the most powerful way in which human rights are normally dealt with. And the UN system, that's basically the methodology. Because all they can do is say publicly a government has violated its rights. And that government can try and defend itself or whatever. But there's no policeman, right? The whole international law idea, the classic critique as well, there's no big policeman in the world to go around and ensure that rights are fulfilled. And it's all highly politicized. One hand, we want to be friends with the fellow who runs the Philippines, despite the fact that we know there are many problems in terms of how he's doing policing there right now. On the other hand, we say, but the fellow in Caracas, in Venezuela, he's clearly violating rights. We need to do something about it now. This is highly politicized as one of the problems with the enforcement of human rights. Everybody says, that person's good, that person's bad, and that's the choice. But what happens when we try and get it down to a level within countries, right? How do we enforce rights there? The naming and shaming game for NGOs is still part of the game, right? The media and that, get the stuff out there, make sure that people know so that something can be done. But what happens when we talk about it with respect to court enforcement? Let's do these positive rights. A right to health. How does that get enforced in the courts? There's two sets of examples that I want to just briefly talk about. The first set of examples come out of South Africa. The second set come out of many Latin American countries, and a number of I've got Latin American visiting scholars here who can tell you more about that than I can. But the essential mechanism on the Latin American side is individual, in the sense that there's a legal mechanism in law in Latin America called the tutela. And that enables you to go as an individual to court and say, my rights aren't being fulfilled. And it's been done quite a bit with respect to access to medicines. You get a prescription from your doctor, and you go, and the public health service either doesn't provide that particular drug or that particular procedure, and they say, sorry, we can't do it. You go to court, and the judge says, I think you have a right to this, and we'll sign an order, and now they've got to deliver it. Now that sounds great, right? So anybody needs something in terms of health, they can go along and get to court and get the order and go get it. Some people have had most extraordinary orders granted by the courts in Latin America, enabling them to go and get cancer treatment unavailable in their countries, all paid by the government once the court order is issued, right? This is orders to the government, they must pay out. Now, as health people, you must immediately go, hang on a second. There's a line of people, and it's the first person in the queue who gets it, right? What's going to happen to the guy at the back? And that's clearly become the issue in Latin America. And when these issues have been studied, what becomes clear is that, of course, it's the middle class that's taking advantage of this. Because you've got to have the wherewithal and the resources to get a lawyer to go and do this for you. Right? It's not going to be just the individual out of the poor part of town. Now, some NGOs in that might intercede, but basically that's been the critique now of what's gone on there with this realization of the right to health through individual claims to court. South Africa started out after 1996, where we have a right to the health in the Constitution. The first case was tragic. It's a man by the name of Mr. Subramani, and he was on dialysis. And he went to the hospital in the public system in Durban, in KwaZulu-Natal, and he went to the hospital, and they said, sorry, you can no longer get access to the public dialysis system because your health condition is such that you're not in line for somebody who could finally get a kidney transplant. Underlying health conditions were such that you don't get access. There's only so many machines in the country, so many machines in the hospital, and the doctors basically, they triage this, and they say you can't do this. He went to court, right to health. South African courts, this was their first case of the constitutional right to health came up, and they basically said, what can we do? There's only X number of machines. The doctors have a system by which they can say, the medical system has a system by which they say certain people are likely to benefit in the long term and are more likely to be able to get transplants down the road, etc. Those people are first in line. And if there's not enough time and availability on these machines, you can go into the private sector if you can, but if you can't, there's nothing we can do. And Mr. Subramani dies. So that was like, oh, so much for this right to health. Right? That was the first response. What was interesting is the social movements, because it was also a period where shortly thereafter the HIV/AIDS pandemic hit South Africa really hard. And what happened was the social movement took a look at this and said, how do we address this? The Treatment Action Campaign began mobilizing. And they realized that if they went to court and they said, you need to provide, because this was 1996, so antiretrovirals were just coming onto the market. The case finally gets to court around 2000. And so antiretrovirals are available, but they're $10,000 a year per patient at that time. There's no ways the country could afford that. But they went to court on a very specific issue, mother-to-child transmission. And they had said that nevirapine was a much cheaper alternative. And if nevirapine was provided just before birth to the mother and just afterwards, the drop in the number of children being born HIV positive would be dramatic. That's what they were able to show in court. They also got lucky because they managed to get the producer of nevirapine to agree to provide a 5-year supply to the country free of charge. So they took away the resource issue. And in that context, the court said, what justification can the government say that they wouldn't provide this through the public health system? The court there, taking that into, said, under the right to health, the government cannot. It's not rational for the government to preclude. Of course, this was using a wedge. So this is part of how human rights get enforced. There was a social movement finding a way to get this issue into court, to open up the delivery of antiretrovirals, that form of it, to one particular group. And of course, as soon as that started, the demands very quickly came, well, what about everybody else? That never went to court. There'd been a prior case with the pharmaceutical industry. The government has started to talk about breaking patents, and the pharmaceutical industry had gone off to court, and it looked very embarrassing. It was the Pharmaceutical Manufacturers Association versus Nelson Mandela. It didn't look good. Right? Globally, it just didn't wash well. And there were groups in the United States who took the issue up. Al Gore started his campaign for president, and at the first campaign meetings in Washington, D.C., there was ACT UP outside saying, you're killing black South Africans, because the U.S. was insisting on patent protection. And very quickly, Gore said, we've got to get out of this. We've got to get this off the table. And they started negotiating some alternative. And that was the origins of PEPFAR. I mean, it was Bush who put PEPFAR in place, but that was the origins of the negotiation for PEPFAR, where the negotiations with the companies were such that eventually you get a cheaper form of the drugs provided. But that brings me, and I'll try and be short so we can have time for discussion, to this whole question of access to essential medicines. This is the wonderful old WHO original frame of access to essential medicines that was developed from the 1970s. And what was interesting, access was all about the rational selection of the drugs. The affordable price was one of the determinants, because the way this worked, and it's interesting because if you think of international organizations, they operate so differently depending on who are the main players within them. So the WHO, how does it work? Right? So you get organizations like the World Trade Organization or the UN itself, and they operate by getting agreements, enforcing agreements, finding ways to get those agreements enforced. Not the doctors, not the World Health Organization. Because the way medicine operates, or likes to operate, is here's a model. Here's the best way, and you can copy it. That's precisely what they did. Right? The whole essential drug system works by, we have a model list of essential medicines, and governments can adopt this list. The World Health Organization, from its founding, had the power to form treaties among its members that would then be enforceable. Never used that power until the Tobacco Treaty. But 70 years in nearly, or whatever, before they actually use that power that they have as an organization. And again, the way I look at it, and I did work, and I was going to WHO and talking to people, there was, well, how many lawyers did I find in the building? A handful. Basically, the doctors ran the place. And they just didn't think about it in those ways. So it's really interesting in terms of the governance, how these organizations work. They're quite different. I'll talk in a moment about those trade people. But this framework, of course, didn't work initially for HIV/AIDS at all. The new antiretrovirals couldn't be on the list. They were not at an affordable price. There was no sustainable financing. And it took quite a struggle to say to the WHO, hang on, these things have to be on the list if you're going to address this pandemic. And eventually they were put on the list. But it's the way the system works was, this is a much more effective way. What you don't have stated here, it's hidden behind affordable prices and sustainable financing, is basically it's generic drugs. That's why they couldn't put the antiretrovirals on when they first came onto the market, because they were. And everybody knows the difference between the price of a brand and price of a generic. What's fascinating, what I learned about this with antiretrovirals particularly, was if your price comes in at 10,000, the first generic goes on the market, it brings it down to 750, whatever, a little bit. As soon as you've got three generics in the market, you're down to $99. That's just what happened with antiretrovirals, and it happens with all medicines. Unfortunately, it isn't that simple in the way generics emerge, because companies now start specializing. So today, I mean, why is insulin at the ridiculous price it is? Not because of because of patents anymore, way beyond patents. It's because only certain companies specialize in producing it. Basically, they make their own monopoly. Right? Where else are you going to go to get it? So yeah, I referred already to the different ways these organizations work. So the WHO I've been characterizing as this works with models rather than decisions. But what's amazing about all these organizations, they often have very different ways of functioning. And the one that matters here is that dear thing called the World Trade Organization. Now, it's in a lot of trouble right now between China and the US. It's getting battered around. But when the World Trade Organization was formed in 1995, they did something interesting. They changed the way international rules work. So all international agreements before 1995, so if you think about those human rights agreements that have the right to health embedded within them, countries could sign on and could agree to limit their commitment. Right? And the way they did that is something called a reservation. So the United States signs on, for instance, to the political and civil rights, but has a reservation saying that basically, although the treaty includes requirements to regulate hate speech, because of the First Amendment in the United States, they reserve out of that. Right? So you can agree to be part of international agreements and say, I can't be part of this, and that part of it. Often very problematic, right? So you get countries that agree to be part of an international human rights agreement, but once you read their reservations, they haven't made much commitment at all. Right? So the reservations is problematic. On the other hand, you go with something like the World Health with the Trade Organization. When they formed, they said, okay, it's in or out. You either accept all the obligations or you can't be a member. There's no reservations. Right? The countries had no choice. And part of that was, embedded within this, was something called the TRIPS Agreement. International Agreement for Trade-Related Aspects of Intellectual Property. What's interesting is there's another organization called WIPO, if you can find it there somewhere, World Intellectual Property Organization. Oh, it's not even there. But there's something called WIPO, which is one of the UN member organizations like this. And WIPO is supposed to be the intellectual property organization that runs issues around intellectual property around the world. But like every other international organization, they have two elements. You can reserve out, so you could agree to respect intellectual property, but you could say, but not for medicines. Right? That would be perfectly acceptable. And in fact, that's why India, even though they had patents for process patents, no product patents. And that's why India became the pharmacy of the world. Because as long as they could work out how to make the drug, reverse engineer, and make the drug in a different way than somebody else, they got a right to do that, right, under Indian law. There was no product patent. When they joined the World Trade Organization, what happened was the international pharmaceuticals, the international entertainment industry, and computer industry got together and said, this WIPO thing doesn't work for us. We want harder rules. So they took the intellectual property issue and they took it and said it's a trade issue. That's why the agreement's called Trade-Related Aspects of Intellectual Property. Because intellectual property, after all, is supposed to be over in WIPO. So you choose the subject matter and you take it with you. And they put in this new organization where you're either in or out. And once you're in, all decisions are now made by consensus. No majority decision making. So you're locked into what is. To change it is very difficult. Any country that accedes in, that agrees to become part of the World Trade Organization, has to accept the whole package or they're out. That was how the TRIPS agreement became this dominant agreement, not for long, right? 1995 is when it came into force, and then the HIV/AIDS pandemic breaks out. And the next thing, we're sitting at the Doha for the next round of negotiations on trade, and this is 2001. And what happens is, developing countries say, look, we have this HIV/AIDS crisis. We need to get access to generic medicines. They say, well, sorry, there's the rules. The rules are that we have, you must respect patents. They said, well, then we're making an exception for public health. And what's interesting, in the negotiations, the US, the EU, Japan were like, no, these are rules. And eventually somebody turned around in the negotiations actually and said to the US delegate, excuse us, what just happened after 9/11 when you had that little white powder that was being distributed around? Well, what did you guys do? Well, the first thing the US did was issued a compulsory license against a Canadian company that had the patent for the drug that was going to be used if, in fact, there was a major anthrax outbreak. And the US, the first thing they did was compulsory license, we need that, which was the power and their right to do that. But now they're saying to the rest of the world, under the WTO, you can't do that anymore. They said, but you just did it. So we got that exception. That was how we got the Doha Agreement that now says public health exception with respect to access to medicines. Problem, we know that it doesn't work very effectively yet. There's lots of fights about it. The biggest fight is immediately they put an exception. Here's how lawyers play. They put into the exception, for example, HIV/AIDS, TB, and malaria. For example. So the developing world says, those are just examples. We must be able to get drugs, generic drugs, on everything. Cancer, other issues, of course. And the developed world says, no, it's only those three. Can't you see? That's the legal fight right now. Right? Is it just those drugs? And then if you think about how the whole period after that became, these are the three big diseases we're going to deal with in the world. All the philanthropic money and everything poured into HIV, malaria, and TB. Well, what about the rest? So the ways in which these things are framed becomes absolutely central. That's just a map of access to medicine. I like showing it because you look at Africa and you realize where people don't get access to medicine. I mentioned already the fact that different constitutions have these rights within them, different degrees, right? The US Constitution, a much older constitution, doesn't have this. But it's only because of its age. What did FDR do at the time of his For Freedom speech? One of the issues that he rose was we should be introducing social and economic rights into the US Constitution. Because they never happened. But it was part of a debate at one point, and now you hear all these discussions going on today, and you realize that it will return as a debate. But what I'm fascinated in is I found these two things, both Amnesty International and another nice one there. Healthcare is a human right. That's very different to saying that there's a human right to health. This suggests that I have an individual right myself to care, which has very different implications in terms of the nature of rights. But I don't think there's anything wrong with that. I think people should have that right. But if you think about the implementation of rights, that's going to have a very different implication. Right? That's going to get us probably closer to the issue that's going on in Latin America now, where a government can't evaluate where the resources should go if the courts are saying, here's this person, they need this, now pay. And the one behind them, and the one behind them, and the one behind them. And so the whole way, there's a very interesting paper I read critiquing the ways in which, if you expect health ministries to have a rational basis for how they're going to allocate health resources to achieve a right to health, if you have a legal system which says, I can stand in front and get there first, just because I got through the door first, that's going to be very problematic. And they're having to think about how to manage this issue in that context. But many countries are going through that. Brazil, Colombia, They're dealing precisely with that issue right now. So the right to health recognized at the level of individuals being able to claim. Sounds great. But there are other issues that you have to think about in relation to it. The critique of the South African one is all very nice to say that you have this general right to health when the government can afford it and when it's supposed to be spending on it, but you can't actually, how do you enforce it? How do you make it happen? There, I think the story was you have a social movement. It's part of a political process as much as a legal process. It's just not one thing or the other. Let's stop there and open up for conversation. Otherwise, I had some ideas, but this was the last one. It's interesting. Here's the World Health Organization. In the corner here, stand up for your human rights, and making the very important point of, and I think that's what your next talk is going to be about, right? That what you mentioned. The next is going to be, well, what does it mean? Because it's one thing to say you're a citizen of a country, and if you have certain demands you can place on the society that you're part of. But then what happens if you're a refugee or a migrant, and somehow puts you in a separate box? Is health something that is tied to citizenship? Or is health something that every human being has a right to? But let's open it up for conversation. I think we've got, they put these marks here.
I heard you say at the beginning a few times, Alma-Ata. What do you meant with that?
Sorry, Alma-Ata was a city where the World Health Organization held its meeting in 1978. They came up with this declaration was about primary health care being essential.
All right, that's exactly that.
Sorry.
It used to be, in my time, used to be called Alma-Ata, Kazakhstan.
I may have just mispronounced it.
Yeah, which now they call it Almaty. But Alma-Ata in Turk is really apple father. And they're the best apples I've ever seen on this planet.
Okay. And healthy, no doubt.
Healthy, yes.
So thank you for the great talk. My name is Sarah. I'm one of the faculty at the School of Pharmacy. And I'm also Egyptian, which is interesting because we had this hepatitis C epidemic, like 1/5 of the population of the Egyptians have HCV. And when the Sovaldi came, which is from Gilead, the pharmaceutical company, in 2013, the cost was $90,000 for the 12 weeks treatment. So Egypt had to reject the international patent law, and they started synthesizing the generic for $900 only. So my question is, what are the consequences for these countries if they rejected the TRIPS agreement and they just started to synthesize whatever generic? And also, for every country, would the people be able to force the government to do so, like reject the international patent as part of the constitutional right for access to medical care?
So there's two problems with this, right? And there's two different ways in which it's managed or gone around. I think one of the interesting things is the pharmaceutical companies have learned that just trying to insist that all these countries pay up when they can't afford to actually is not the way to go. So you've got a lot more negotiation now going on. They've also done something interesting with some of the generics out of India, is the big pharmaceutical companies now actually negotiate with them so they produce the generics for the US market. And then they're less likely to go and break patent elsewhere, which is a little problematic. But in terms of that particular such scenario, what is happening there is that, and India is doing this quite effectively, is they're challenging the patents themselves. Because patent law, at the patent level, you have to show that you really have come up with something completely new. And so domestically, they are now asking the question, which our patent people have been reluctant to do in the US. Well, is this actually new? Is this actually producing a new drug? Or is this greening a new thing or doing something else? And so that's the way in which they challenge it. I don't think Egypt publicly said we're violating TRIPS. What they'll say is, under the TRIPS exception of Doha, we have a right to do this. Now, are you going to take us on? right? And I think that's what developing countries have learned. Trouble is, how many developing countries can possibly take that strategy? Very few. Because how many countries actually have the ability to produce active ingredients? A handful around the world. Right? So, and most developing countries, South Africa can't even do that. So the way it's been resolved in South Africa is a local generics company has been licensed by the American companies to actually produce the drugs at a generic rate, but not for import back to the US, only for use there, right? So that's the way they're managing this.
So Heinz, I want to shift gears away from the drug treatment and health care access, the right to health care, and go back to your other part of this, which is public health. And of course, more and more in this day and age, we recognize, and the WHO recognizes, health in all policy. I see Tom Oliver over here who teaches about health in all policy, and that, you know, how far do these the rights for health go into these other sectors, like the right to have clean air that kills 1 out of 8 people around the world, and the right for access to alternative transportation when sedentary lifestyle is killing 5.3 million people every year. Where does this come into play with these other not health sector related, but absolutely very key determinants of public health?
So that's one of the reasons I put up those 2 little things about human right to health care, because I think it's quite problematic, right? Because if you shift the claim to human right to health care, it becomes that kind of individual-oriented, I have a right to go to court or whatever to demand that I get treated. And you don't have ways to actually get at those much broader issues. So how can they be resolved? Well, supposedly by democratic pressure on a government to put policies in place. There's no court in the world that will say to a government, you've got to change your transport system. Right? The courts just do not have that capacity at all. So one example that I find interesting is the treatment action campaign in South Africa. Having succeeded in pushing the government to finally deal with HIV/AIDS, they've also realized that the actual healthcare system is failing in terms of the hospitals, etc., because of lack of resources, because of corruption and other things going on. They've started now taking action both through social movement activity, but also through the courts to put pressure on the government to actually address the healthcare system. That begins a kind of strategy which says, now we can look more broadly and say, you need to get the systems in place, and then start challenging policy. So now if we can start challenging policy like our electrical generation policy in South Africa that's so based on coal, and start saying, if you're going to invest in another coal plant to produce electricity, the alternative is, instead of going solar or whatever, you have to show us why that's absolutely necessary, because these are going to be the health consequences. These are going to be the costs. So I think it's starting to become part of that discussion. And that's the only way. I don't think that the right to health helps us there much at all. It's the right to a democratic system that recognizes that health is an important part of it. So there, if the right to health gets framed much more in this moral sense. If you had a medical profession who said, we believe this is a human right that we need to deliver, then you're building political pressure on a system to actually address these issues. But it never works that you're going to now have a lawyer going to court say, by the way, we have a right to health because it's quite clear that your transport system is killing thousands. What's going to go? How do we deal with that? Good luck. I mean, it's just, in terms of legal realism, that's not good. I mean, so why do that? So Jonathan, why do that? I mean, they do have a good reason for doing it. Why do they do that? A lot of legal cases are brought in order to put things on the agenda. Not because they think they're going to win the case. Because they know they're going to get the publicity, they're going to get the political mobilization by getting it up to court. So that is a legitimate legal strategy, not because you think you're going to win the case at the end of the day, but you're going to get it into the public agenda, you're going to make it part of the discussion, you're going to build the political pressure that might get some change. That's what that's about.
You might help me know then if this is accurate, but it seems like when we talk about health as a human right, and let me just take the nursing profession as an example, and as part of our code of ethics, most of the time we're talking about that as a moral principle. And I know there's some good documents on, I think, the WHO website about more explicating about what right to health means, like access, affordable, access to information, health determinants are addressed, and all of that. And that's really helpful in sort of visualizing what we mean by right to health, and then how we talk about that in a moral sense, because we could say, yes, we want everybody to have access or access to information. But then there's another parallel conversation, which is about the legal right, and that's really at a governmental level. And we might be traveling for global health, and notice the country has that in their constitution. So then there might be certain expectations. But those conversations are kind of different. And most of the time, in our general dialogue in Madison, it might be about that moral belief that this is what people should have. Is that kind of correct?
I don't think that's wrong, except the thing is, what do you do with that moral thing, right? So if you're using it to train people that they have certain obligations with respect to promoting health, which on the one hand, of course, would say that they should never engage in a protocol for research or whatever that would violate people's rights somewhere else, right? So they should be able to say, regardless of what the locals are happy to do, oh, legally you can do that here. You should hope that somebody would be able to say, actually, from my purely moral perspective of the right to health that I've been trained in, no, I don't do that, right? I mean, that's the one thing where you'd hope that you'd have that kind of impact. But another one might be in terms of that kind of mobilization, in terms of just democratically, what would we be demanding here if we actually believed in these rights, that we believed the population actually had a right to them. That might put us in a certain position with respect to our democratic claims of what we might want. It goes beyond just an individual moral duty.
I'm curious how this statement how the World Health Organization would look at the rights of the refugees in Greece, in a country that can't really afford to take care of themselves as well as the refugees. And particularly about mental health is what I'm thinking.
Right. So there the World Health Organization supposedly is saying to its member states, which includes Greece, that you shouldn't treat folks different. They shouldn't be considered separate. And we all acknowledge immediately that if Greece was expected to have all these folks within the system would probably collapse. So where are the pressures? I suppose the World Health Organization is saying to the EU and to others, you need to support here. You need to make this, you can't just say, sorry, these folks are separate. They don't get these benefits, but they don't deserve a human right to health. That's not possible. And so you use this kind of positioning to say, where are the resources? I don't think, and again, in a way, what this is also saying is, it's not just a question of the country of Greece. The global responsibility to address this issue.
Thank you. I think our time is about up. We have one more question. Did I see somebody's hand? Yes.
Yeah, Heinz, I think there have been a couple of questions that started to get at this, especially the last one here. But if you have a right to health or health care, where are you allowed to exercise it? And it seems like the European Union in particular, not just with an inflow of people from outside its borders, but within its borders, has struggled to where with a freedom of movement, where can you go if you have, say, chronic disease or something that requires expensive medications? Can you basically shop or do medical tourism on a more permanent basis within those borders? And of course, in the U.S., we have distinguished between people who have been here and people who have not been here. Even legal immigrants can't get into the Affordable Care Act coverage. So how do you struggle, or what do you see happening with the right that is given some credence and respect, but will break systems if everybody can go to shop for the place that they can get their one thing that's really necessary?
So, I mean, if you think about how the EU is trying to manage this, right, because it clearly is an issue, they try and manage it by saying, okay, individual member states need to give health insurance. And then the question is that health insurance recognized in another member state? Right? That's how they're trying to manage it, not very successfully. But it is precisely that set of problems. If we acknowledge that people have a right to health, what happens if a Polish worker is working in London? Does that mean that they don't get access there? They've got to go home to Poland because they broke their leg? Obviously not. So you have to have some way of transmitting across that. They're within a system where everybody's recognized that they legally have a right to be there. Right? Not talking about refugees and others for a moment. So there's this question, and that's a whole human rights question. Do you have a right because you're a citizen? Or do you have a right because you're a human being? The human rights claim is you have a right simply because you're a human being. Got nothing to do with whether you're a citizen or not. You're a human being, you deserve that right. But obviously, the governance systems that we now try and put in place to make those things, even if we want to make it work, have to deal with exactly that complexity. Because who's going to pay for it where? Right? And do we put more emphasis on the preventive side, instead of just on the delivery of care side? Right? How do we manage that? Again, it's an allocation of resources that has to be decided at some level, usually, hopefully, democratically, right? As opposed to saying, first in line, I got there, I managed to get to this place where the best care is, and I got there first. I get it, and somebody else is not going to be able to. That obviously doesn't work. Never has. Right? Maybe for the very rich, but for most it doesn't work that way. So how does one manage that? And I don't think simply asserting the right to health does it for us. And that's why I think that systems of governance are so important to how we think about making these rights real.
I think our time is up, and I expect Dr. Klug might stay for some individual questions if you have them. And I want to thank you. This was it was clarifying and thought-provoking. So thanks for being here. So join me in thanking him.